All right, so the question is, higher risk, particularly elderly folks that need procedural sedation, ASA class 3, is this a good idea in the community, and should more of these go to the OR? I think that we probably do way too many of these. There is a type of place to go to the OR. Sometimes we think because we can do it in the ER, we should. Some of those really terrible abscesses, they're just enormous, and you're just cutting and cutting, and the patient's miserable. You know, just because you could do a procedural sedation in the ER doesn't mean that this is a procedure that isn't better done in the OR. And for those higher risk folks that are particularly frail, strongly consider it, particularly in the community setting. Like that young 22-year-old that popped out their shoulder, you could do almost anything you want to them, and they're probably going to be just fine if you take reasonable precautions. That 85-year-old, like, there's a reason that we have anesthesiologists that are very carefully monitoring in the OR all their vitals. And it's because that's what they do. Like, this is their gig, and it's okay. It's not a sign of defeat to say, look, this hip's out of place. They've got a million comorbidities. Let's go to the OR. That is not failure. That's just appropriately saying, I don't think this is a good idea.
I mean, for me personally, I'm asking myself, what's the urgency of this sedation? All right, what is the urgency of this sedation? It is not urgent, and they are high-risk sedation. I'm not doing it. I'm fine swallowing my pride and calling anesthesia. That's what they're paid to do. Let them do it. Let them come see the patient. Let them take the patient to the OR or do it in our environment. That's fine, and if things go south, I think you did the appropriate thing. The couple times that I've ventured outside my comfort zone a little bit in procedural sedation is when it's really urgent. So a severe GI bleed. So I had an elderly patient with a bleeding ulcer, and it was a weekend. It was a Sunday, after hours, and it seemed like getting anesthesia there was becoming a issue for the patient and patient safety. So I felt the need to go ahead and take care of the patient. Let's stop the hemorrhage. Maybe like a native hip, have a ton of time with that. If you got a class 3, you still probably should try anesthesia. But if this is going on and on for an hour or 2 hours, for me, I'm doing the sedation because I want to help the patient. I think it's the right thing for the patient. So I'm asking the urgency first off. If it's urgent to emergent and it's going to take too long to get somebody else to do it, I will carefully do it. Probably keep them light. Ketamine, something that's going to allow them to ventilate